So I'm Dr. Marli from Rensburg, and I'm one of the doctors working at Rahima Musa Mother and Child Hospital Emergency Department. And tonight I'm going to talk to you about how to conduct brainstem testing. This is something that I think is core knowledge for any doctor working in the emergency department. So just to start us off with a quote, I don't fear for physical death, but when my conscience dies, that is real death. So when we're going to talk about brain death or death in general, we need to know a few definitions because death is actually categorized into brain death or circulatory death. So death itself is the clinical point of irreversible loss of the capacity for consciousness and therefore the irreversible loss of the capacity to breathe. And it's either determined by neurological or circulatory criteria, and this must be made in accordance with accepted medical standards. Ancillary test is a test that you will do in addition to the normal testing that will assist you with the diagnosis of brain death. If we talk about accommodation in this setting, it means to accommodate giving a period of support, somatic support, to allow the family to process the diagnosis of death, because we know it's a very difficult concept to understand, when somebody's heart is still beating, but they are actually dead, in terms of neurological criteria. Okay, so then circulatory death is the preferred term to use when death is determined by on circulatory grounds. So this means that the cardiorespiratory function is no longer there. Coma is then the absence of wakefulness or awareness and the capacity for sensory perception and responsiveness to the external environment. And a confounder is any situation or thing that is present that will obscure the diagnosis. So basically you need ancillary testing to differentiate whether or not it's really brain death or if there's something else at play. And then somatic support is exactly what it says. It's the management to support the body and organ function, excluding the brain after brain death has been confirmed.
In South Africa, we've got some pretty robust health laws. The National Health Act 61 of 2003 actually refers to the brain death criteria for death, and the wording in the document is death means brain death. So legally, this means if somebody has been declared brain dead in South Africa, they are dead. And it's interesting because not all countries around the world recognize brain death as a death.
This slide is just here to remind us about the pathophysiology of brain death. It doesn't really matter what the insult was. The final common pathway is this. So there's neuronal cell damage, either by a physical injury or an oxic injury or cerebral edema or infection or anything that you can think of. But regardless of that initial insult, brain death will occur via a spiral of progressive intracranial hypertension, tissue damage, and edema. And this is a self-perpetuating cycle. So the more tissue edema there is, the higher the increased or the intracranial pressure, and the higher the intracranial pressure, reduced cerebral perfusion, which leads to more anoxic brain injury and more neuronal cell damage, until there's a complete cessation of circulation to the brain. So basically, brain death is then complete circulatory arrest of the brain. So common causes of brain death, I'm sure you guys can name a few. So we immediately think about traumatic brain injury, things like intracranial hemorrhage and oxic brain injury, as in cardiac arrest or drowning cases. Also infective causes like fulminant meningitis or encephalitis, where there's severe swelling of the brain. Other causes, systemic causes like hepatic failure that causes cerebral edema can also be at play here.
There might be other causes of raised intracranial pressure, for example, a severe ischemic CVA with herniation.
You need to think about potential mimics of brain death, because this is probably one of the most important things that you need to do before you even start thinking about doing brainstem death testing. So your neuromuscular causes like Guillain-Barré syndrome or botulism, then hypothermia, severe hypothermia can look like brain death, and then a variety of drug intoxications. And this is actually a very, very big category. But things that come immediately to mind are barbiturates, baclofen, lignocaine, sedatives, paralytics, anticholinergic agents, and even some anti-epileptics like valproic acid and antidepressants like bupropion and tricyclic antidepressants are culprits in this category. Other things to consider are high C-spine injuries and locked-in syndrome.
So this is a detailed slide looking at the neuroanatomy. So the cranial nerves and the afferent and efferent pathways to help with revision. So I'm a visual learner. I like color and pictures. If you're anything like me, then this is the slide for you to help you figure out what cranial nerves we're testing and where they are. You might be asking yourself, why exactly do we want to make a diagnosis of brain death?
So reasons why you would consider a formal diagnosis of brain death or to pursue a formal diagnosis of brain death is if you want to clarify the goals of care. Okay, so if you think, further care might be futile in terms of recovering brain function, then brain death needs to be determined, okay? It also reassures the family that nothing else can be done for the patient, and it avoids future criticism regarding withdrawal of life-sustaining therapy. And you also might need to consider organ donation. You need to have a clinical suspicion of brain death. That's your first step. And this suspicion involves roughly two components. So the one is the patient has to have a catastrophic brain injury that is consistent with the diagnosis of brain death. So severe TBI with signs of raised intracranial pressure, that would certainly make you think of brain death if the patient starts herniating. Then your clinical examination is the second component to this, and this needs to be consistent with brain death. I cannot stress this enough, and therefore, I don't often use capital letters in my presentation, but these ones are stressed. So there must be an established etiology compatible with complete and irreversible loss of all brain function prior to the commencement of brain death determination. Okay, so preconditions for brain death testing: the patient needs to be normal everything. Normothermic, normotensive, no sedatives or analgesics on board. They need to have intact neuromuscular function, and you need to have ruled out any significant metabolic, endocrine, and electrolyte abnormalities before you proceed with this. Next are your logistical preconditions, and this is basically you need to have two independent physicians, and one of the physicians must be qualified for more than 5 years, and these assessments need to be done at 2 different times. So neuroimaging is not routinely recommended, but it is recommended when you need to make a diagnosis or establish an etiology, and if you want to confirm the brain injury, but it's not required for the diagnosis of brain death where obvious causes no. Drug levels. So if you're going to do drug levels, they shouldn't exceed the therapeutic range. Okay, so this is now when you want to start brain death testing and you did drug levels, the drug level should be therapeutic. If it's higher than the therapeutic range, you can't proceed with the testing. So that's what that means. And then if it is in the therapeutic range, the side effects of the drug cannot be associated with an altered level of consciousness. So, and then another thing to remember here is that barbiturates have a long and variable elimination half-life. So blood levels must be below the level of clinically significant effects, or you should do ancillary testing to confirm the diagnosis of brain death. Severe alcohol intoxication, if you suspect severe alcohol intoxication to be the main cause of the coma, then the blood level should be less than 80 milligrams per deciliter. In terms of a standardized observation period prior to brain death testing, there's no consensus on this. It's case dependent and individualized to each case. In cases of an oxic brain injury, the observation period recommended is 24 hours. And where there was therapeutic hypothermia, also 24-hour period of normothermia is necessary before you proceed with a brain death examination. In peds, it's also a bit of a tricky thing, so you need to be very cautious, especially when you approach the confounders in this group. Diagnostic criteria for brain death are based on four things, four criteria, and this is the clinical examination, and this is a thorough neurological exam to assess the brain function, absence of brainstem reflexes, which we'll go through now, the dreaded apnea test, and then any confirmatory tests. So your clinical examination is done to exclude conditions that can mimic brain death. It's a focused neurological examination, and then you proceed with formal testing. When we proceed to brainstem reflex testing, we will be looking at the pupillary response to light, oculocephalic reflex, and oculovestibular reflex, cough reflex, as well as the swallowing reflex. You need to determine that the patient is comatose. Okay, so there's no evidence of arousal or awareness to maximal external stimulation. And this is noxious stimuli like pain in any extremity, pain in the supraorbital notch that is demonstrated here, or at the TMJs, and then there should be or a deep sternal rub. That's the other way that you can do it. And there should be no vertical eye movement or stimulation or command, as would occur in locked-in syndrome.
Assessing the response to a painful supraorbital stimulus involves testing the 5th and 7th cranial nerves, which are the trigeminal and facial nerves.
Next, you will check your pupillary reflexes. So usually when a patient is brain dead, the pupils will be dilated, and there will be no ipsilateral or contralateral pupillary response to light. Okay, so this is a typical picture. It's fixed in the mid position and it's dilated. You may see some corneal clouding, but be aware that barbiturates can definitely cause this type of picture as well. So again, you might need ancillary testing. And then if the pupils are very small, we call that pontine pupils, and that suggests the possibility of a drug intoxication or locked-in syndrome. So that's not in keeping with brain death.
Assessing the pupillary light reflex involves testing the 2nd and 3rd cranial nerves, which are the optic and oculomotor nerves.
Next, you will test your corneal reflexes. Okay, and there are some pitfalls to testing corneal reflexes. So what's demonstrated here is that you stimulate, so you approach from the lateral side, and you want to stimulate the cornea, which is the at the border of the sclera and the iris. Okay, so that's where you want to stimulate it. Okay, you want to touch the lateral aspects of the cornea of both eyes with a cotton swab, with enough pressure to slightly depress the eye. Okay, and the common mistakes or pitfalls here is some people say that they test the corneal reflex with putting in drops in the eye, that's not an adequate test because it doesn't provide the strongest stimulation for this reflex to occur. And then only stimulating the sclera, which is the white part of the eye, rather than the cornea.
Assessing the corneal reflex means that we are testing the 5th and the 7th cranial nerves, which are the trigeminal and facial nerves.
Next is your doll's eye test or your oculocephalic test. And this means that when you turn the patient's head from side to side, in a normal patient with intact brainstem function, their eyes will fix on a position in front of them, okay? So the eyes will not move with the head. So that's the top picture. The bottom picture is when the oculocephalic reflex is absent, and that means the eyes stay fixed in the mid position and it turns with the head in that direction.
Assessing the oculocephalic reflex involves testing the 3rd, 6th, and 8th cranial nerves, which are the oculomotor, abducens, and vestibulocochlear nerves.
Next is your oculovestibular reflex, and this reflex is stimulated when you irrigate the ear with at least 30 ml of ice cold water, literally ice cold water. So you take ice in a bowl and you add water to it, let it stand for a little bit to cool down. While you're waiting for the water to cool down, you want to just do a quick otoscopy to make sure that there's no wax obstructing the tympanic membrane, because then your test, you will have an inaccurate result to this test, okay? So you will instill at least 30 ml of ice cold water for at least 60 seconds into each ear, and you will observe one ear at a time, and you will observe for any movement of the eyes. It's important to allow 5 minutes between testing the different sides.
Assessing the oculovestibular reflex involves testing 4 of the cranial nerves, the 3rd, 4th, 6th, and 8th cranial nerves, which are the oculomotor, trochlear, abducens nerves, and vestibulocochlear nerve.
The next test you will do is your cough and gag reflexes. This is actually quite easy. So if you have an inline suction catheter, that's one that's demonstrated in this picture, you can just suction very deep. And then if the patient doesn't cough to that, then that's the cough reflex is not intact. And for gag reflex, you can test that by suctioning the back of the throat with a Janse catheter, and you should stimulate both sides as well.
So assessing the cough gag, the tracheal reflexes, involves testing the 9th and 10th cranial nerves, which are the glossopharyngeal and vagus nerves.
You need to also know what the observations are that it is compatible with brain death, okay? And this is where I'm going to talk a little bit about spinal reflexes. There's also something called the Lazarus sign, okay? Other signs like autonomic signs, so the patient might be sweating or blushing, they might have a tachycardia.
A patient who is brain dead might have a completely normal blood pressure without the need for any pharmacological support. A patient with brain death also might have the complete absence of diabetes insipidus.
So there's a summary here on the slide of all the different spinal reflexes that you can get. So when I share this, you can have a look through that. Observations that are incompatible with brain death is any posturing, so decerebrate or decorticate posturing, and seizures. Okay, so if you witness any seizures or if your patient postures, you cannot confirm brain death. I'm going to spend a little bit of time here on the apnea test because I think this is probably the most complicated of all the tests to do, and it's something that everybody dreads. Somehow people are scared of doing this. I don't know why, but it is something that people find daunting. So the prerequisites for performing apnea test is that patients must be deemed stable enough to tolerate apnea. So they can't be severely hypoxic or acidotic, okay? Which means the PaO2 on 100% FiO2 should be more than 200 millimeters, okay? PaCO2 is normal or at the patient's known baseline in cases of COPD or obesity hyperventilation syndrome. So if the patient has evidence of chronic CO2 retention without a baseline CO2, the apnea test should still be done, but then an ancillary test must also be performed. Okay, then there should be absence of any confounding factors. Okay, the core temperature should be above 36. Normotensive patient with a MAP of more than 75 prior to the test. Okay, so how you will prepare your patient for this, you will pre-oxygenate the patient with 100% FiO2 for more than 10 minutes. In that time, you will obtain a baseline arterial blood gas sample and ensure that the PaCO2 is normal, so that's between 35 and 45, or at the patient's known baseline. So if the patient is a known COPD patient and you're able to go back into the file and you see that the normal CO2 is, for argument's sake, 50, then that PCO2 should be at 50 because that's normal for them, okay? And then you should be able to ensure continuous blood pressure monitoring during the test. So either cycle your cuff for every 5 minutes or so, very short intervals. You can either do every minute if you want, but the ideal here would be to have an A-line, but you don't have to put up an A-line to do this. Okay. You can also consider initiation of a vasopressor if the blood pressure is borderline when you need to do this test, okay? Because apnea may cause hypotension, and therefore you need to be able to, you need to be sure that you won't cause that. So preemptively, you can initiate something like adrenaline to establish a margin of blood pressure stability before you conduct the test to avoid having to abort the test mid-test. Okay. So now that you've pre-oxygenated your patient and you've looked at your blood gas and you've looked at the clinical stability of the patient to conduct the test, the goal is now to stop the ventilator. Okay, so essentially you have now denitrogenated the lungs. So you have created some reserve of oxygen within the lungs. But what you want now is you want the CO2 to gradually rise so that that becomes a trigger for respiration. Okay, that is the goal of the apnea test. So you want to stop ventilating the patient, but provide supplemental oxygen at the same time because you don't want them to deoxygenate. And you can do this by providing some continuous positive pressure to prevent the recruitment of the lungs.
So there's a couple methods of providing continuous oxygen during the apnea. Turning the ventilator to a CPAP mode with no backup rate. Kind of difficult because most ventilators will kick in with a backup to make sure that the patient gets adequate tidal volumes. You can use an anesthetic flow inflating bag to provide oxygen and set CPAP, a T-piece kind of method, and then a slightly older method which is less favorable, but if it's the only option that you have, you can use it. Popping a cannula with oxygen down the ET tube. Just bear in mind that risk of complications, pneumothorax is highly possible with this method. An alternative to it is to use an oxygenating tube exchanger.
I pre-oxygenate the patient and then I connect a BVM to the ET tube, and I just add a flow of 15 liters per minute with my reservoir bag. Okay, and that's how I do it. So you disconnect the patient from the vent completely and then just to a BVM without bagging them. Okay. Then you observe the patient for a few things. So first you need to observe for any respiratory effort. Okay. If there's any sign of respiratory effort, the patient is not brain dead. Okay. So then you have to reconnect them to the ventilator immediately and resume supportive care. Okay, and then you can consider repeating an apnea test after 24 hours in order to have a positive apnea test, okay, which means the patient has no respiratory drive. You are looking for a pH of less than 7.3 and a PaCO2 of more than 60 millimeters of mercury, okay? So patients with pre-existing hypocarbia, like your COPD patients, you should look for an increase of 20 millimeters of mercury above the patient's baseline. Indications to abort the apnea test prematurely is if the patient becomes hemodynamically unstable, so MAP less than 75 or systolic blood pressure less than 100. If there's a sustained desaturation below 85% for more than 30 seconds, remember you're giving supplemental oxygen during this time. So if the patient desaturates despite that, then you have to abort the test. Also, if they have an unstable arrhythmia, just remember that apnea testing is not indicated in patients with hypoxic respiratory failure or high cervical spinal cord injuries. These patients need ancillary testing after brainstem reflex testing to confirm the diagnosis of brain death. Okay, so confirmatory tests that you can do. So first of all, you need to know when would you do these confirmatory tests. And like I've said before in this presentation, if there's any confounding factor, like a barbiturate or a metabolic derangement or something that cannot adequately be corrected, then you will consider doing a confirmatory test. Also in a situation where you are unable to perform an apnea test because the patient is too hypoxemic or unable to tolerate the apnea, if there's any uncertainty regarding whether the movements are spinally mediated reflexes. And then in some countries it might be like a legal thing to do it. Okay, so the test that we use is, the most useful confirmatory test is cerebral scintigraphy. And this is basically a radio-labeled dye that's injected, and then they look at brain perfusion, and there's a sign that's demonstrated on this slide that's called the empty skull sign, and you can see that there's like lack of blood flow to the entire brain, okay? And this is solid evidence of brain death because that is actually the pathophysiology. There's no blood flow to the brain. The other way that is probably more available to us in the emergency department, but you also need to be a little bit experienced and know what you're looking for, is transcranial Doppler. And this can show absent flow. But if you have poor bone windows, the result might not be very reliable. So as with any ultrasound thing, it's operator dependent, but it is an option. All right. This is just some pictures of transcranial Doppler imaging, and in the last picture you can see these sharp peaks, okay, but that's actually absent flow, okay, so there's zero flow to the brain. So if you see that, picture A is normal and picture D is very abnormal, and that means that the patient is brain dead. Next is probably one of the most important things, documentation. The brain death certification is a form that goes through all the prerequisites and then the examination, and you have to document. There's a column for Dr. 1 and a column for Dr. 2. Okay, so you're going to look at your prerequisites, which is coma irreversible and a known cause, normothermia, systolic blood pressure of above 100, significant metabolic, electrolyte, and endocrine abnormalities have been excluded, and then no sedatives or neuromuscular drug effects are present, okay? And then you will move to the examination, as I explained in my previous slides, and then you will confirm your findings and you sign at the bottom as Dr. 1 or Dr. 2. And once this has been signed, then that is your time of death, okay? So once you've determined that the patient is brain dead, that is your time of death. if you need to do confirmatory tests, at the point when you get that test result, that is when your patient is brain dead. The next step would be to communicate the diagnosis to the family. Okay, and this is something that you will need to practice. You need to communicate this in clear terms, not medical terms. So layman's terms, you need to be able to explain to them that the patient is dead. Okay. A good framework to use for this is, you select the right setting, choose a private area, ensure that the patient's family members are comfortable and have enough time to process the information. Okay. Then you prepare them. Okay. Or you prepare yourself first. So you review the case history if you're not familiar with the patient, and then prepare the family members emotionally to sort of preempt that you're going to be delivering some difficult news to them. Always introduce yourself and express your condolences to the family situation, and emphasize that you are there to provide support. Okay. Like I said, initially you have to communicate very clearly. Okay. So use simple language, avoid medical jargon, and explain that brain death means irreversible cessation of all brain function, including the brain stem, which means 0% chance for recovery. So the patient will not wake up. There's 0 chances for that. You can also tell them that the patient will never breathe independently again. Okay. So then also provide some emotional support, okay, to them. Allow them to ask questions, listen actively, and be empathetic towards the patient's family. And then discuss the goals of care, not discussing the options, okay? Remember that this is a challenging situation for both you and the patient's family. So just, if you need to take some time for yourself to deal with this, that's also okay. Organ donation is something that I feel very strongly about. I think it's, we should actually have an opt-out system rather than an opt-in system, but that's just my opinion.
If you need to get hold of the transplant coordinator, please hold on to this phone number. It's Anya Meyer's phone number, and she is the senior manager for the transplant coordinating team for the state Johannesburg hospitals. So if you work at Helen Joseph or Rahima Musa Mother and Child Hospital, this is the person to contact. In summary, there's 3 things I'd like you to remember when looking at brain death and brain death testing. First thing is that in South Africa, if you are brain dead, this means by law that you are dead. The second one is to please remember the anatomy, looking at the cranial nerves that we actually are testing as part of our brainstem testing, and use a checklist. It makes it so much easier for documentation and to remember everything as well.